If you step back for a second, if you look at where the United States ranks compared to other developed countries, we're somewhere at the bottom. Not something we should be proud about. There's a lot of things that are happening outside of just core obstetrics care that are driving that preterm birth rate. So if you think about the chronic disease burdens that makes pregnancies at risk or high risk, you have obesity, diabetes, and then you have greater access to fertility treatments, and then just the stats that women are having babies later in life. All of these things are confounding variables that are driving us in the wrong direction.
Thank you for joining us, Mr. Andy Wagner, leader at Hera Women's Health. Thank you for being here on the Athelis Taking Back Healthcare podcast.
Thanks for having me.
Amazing. It'd be great to kind of dive in and just hear more about your background and what led you here.
Sure. Well, I don't know how far you want to go back, but, I'll start with, I'm a recovering ER doc. I practiced for quite some time, but haven't, if I'm honest with myself, seen an actual patient in about 8 to 10 years. And my journey after medical school started with what I think is probably a pretty lucky break. I started working for a ER staffing company that had a need for somebody to manage an investment fund for them. I showed interest, had just gotten out of business school, and so spent about 5-6 years helping manage a small investment fund that invested in disruptive healthcare technologies. And along the way had the opportunity to join a telemedicine company, part of their management team. This is, way back before the technology that we use every day actually existed, and was kind of at the forefront of what we now think of as just standard telemedicine. Over about a 3-year period, we turned growth around, matured the technology, and ultimately sold it to Teladoc, which was really where I cut my teeth in what I would call the tech-enabled space, and just absolutely fell in love with marrying new technology and new models of care with traditional provider services. After my stint at Stat Doctors, joined a company called Dispatch Health. This is very early on. The two co-founders and myself basically divided and conquered in the early years. Fast forward 7 years, we had developed an ER diversion model that brought a nurse practitioner and a medic to the home, and really ripped out about 90% of the cost of delivering emergency care, but did it in the home. So just to be clear, strokes, heart attacks, big bad stuff belongs in the ER, but there's a lot of other things that could be safely taken care of at the home. That company then evolved into a hospital at home vertical, mobile imaging vertical, and was ultimately, or still today, building a distributed healthcare system in the home. That was an incredible experience. So I, had experiences building revenue cycle management, healthcare regulatory. I ran clinical as their chief clinical officer, did a lot of core operations work. And then about 7 years in, decided to call it a day, and spent a couple years just doing independent consulting. Frankly, picked up yoga, lots of different hobbies.
After all that, you got to get Zen.
That's right. You do. When you have a lot of time on your hand, you got to start filling it. And then, ultimately you sort of get itchy, right? Yeah. I will tell you, I now know retirement is a myth. I think retirement is really choosing when and what you work on. Mm-hmm. And then about 6 months ago, I joined as CEO of Hera Women's Health, which is a really interesting model. And look, I'm new to the women's health space, and I've got about 6 months under my belt and still learning. But the genesis of Hera was that Dr. Irier, who is a MFM specialist, former president of their big society, had built a impressive private practice in Vegas and Reno. And Brian and a capital partner came together, and really with the thesis, if we combine maternal fetal medicine specialists with OBGYNs, you can improve clinical outcomes for moms and babies. And to date, that story has, or that thesis has proven true. So the outcomes of this practice, and it's really what brought me to Hera and got me interested, is incredible. Preterm birth rates that are drastically lower than local national averages, appropriate C-section rates that are just as equally impressive. And all of that leads to both optimized reimbursement from payers, because you're starting to take cost out of the system, giving them more flexibility to reward physicians, and then really do what we as physicians really signed up to do, right? Is to deliver awesome care and be able to, see the product, which in this case is a beautiful baby, right?
Right.
I during one of my first days as CEO, I toured all of our practices, and it just took me back that these practices are filled with pictures of beautiful kids. And a couple practices, moms were actually bringing their babies in to show their babies off. I never had that experience as an ER doc, right? Very different specialty, right. Very different circumstance, but really cool to be part of an organization where your goal is to celebrate what I think as a parent is the most amazing thing in one's life, right? Having a baby and raising kids. So that's sort of my journey to today.
Amazing. You have a very fascinating background, very all over the place in a good way in terms of med school, MBA, investment. You talked about consulting, but then you also touched on your interest in these different models of healthcare offered. Obviously, Hera has a very compelling model itself, and so I was hoping you could dive more deep into Hera's model and maybe what are some takeaways that other practices could potentially incorporate that they aren't taking into consideration right now.
Yeah. Well, I think first is probably important to step back and just think about the women's health landscape, and that will probably help me differentiate Hera and why we think we're different and unique, and then maybe we can talk a little bit about where I think the organization is going. And so, there's been a ton of capital put into women's health over the last decade, and I think it's great. It's been completely underfunded and very much needed. And if you step back and look at the models, there's a lot of rolling up physician practices, getting to scale, and then building out the different verticals of care, right? And so just recognize that when we say women's health, that includes preventative women's health, general gynecology, obstetrics or moms and babies, infertility treatment, the menopause treatment. The list goes on and on and on and on. And there's been very successful companies that have purchased or partnered with OBGYN practices and then built out those verticals. That's sort of one archetype, I guess. The other one that I think about a lot is women's health that are pure telemedicine companies. And there's been a lot of successful ones in doing the broad approach or in very specific verticals like menopause. And those are really targeted, I believe, at companies, self-funded companies. And if you think about the workforce is becoming more and more female, the demands for women's health benefits are becoming more prominent. And so those companies are addressing that niche. I think that traditional brick and mortar medicine has its place. Telemedicine has its place. I think what a lot of people refer to as click and mortar, combining brick and mortar with telemedicine is absolutely the future. And so you see some of these companies, these telemedicine companies, trying to go into brick and mortar, which I think is much harder. I think it's easier to go from brick and mortar into telemedicine. And so that's one of the things we're going to be doing. So I talked a little bit about Hera and the genesis. I think it's important to think about Hera as broad as we offer all of those different services we talked about. And I think you need to, because you need to take care of women of all ages with all problem sets or issues. But we think of ourselves as a hyper specialized in the obstetric space. So when I wake up, when our providers wake up, when my folks wake up in the morning, we're thinking about how do we improve the preterm delivery rate, and give every mom and dad the opportunity to have a healthy baby. So that's sort of how we think about it. I think in terms of the future of Hera, there's a couple things. One is we are very focused on evolving our MSO capabilities to preferentially partner as opposed to acquire practices. We will, and we are doing strategic acquisitions, but we are also looking at what I think about as a modern day MSO. I think there's a lot of technology advancements that are going on that allow a different type of MSO operation than you could have had 5 years ago. So that's number one. Number two is we're going to double down on obstetrics care and clinical outcomes, and are a lot quicker than I thought headed towards some pretty meaningful value-based care contracting structures. And then lastly, we are laser focused on expanding care into rural America. And a couple things about rural America. 30 to 35% of counties in the United States are maternity deserts, which is defined as really no obstetrics resources in those counties. That's about 2 million women of childbearing age that have no access to care, or more pragmatically have to drive really far. And the result is the outcomes are 2 to 5x, depending on what you read, worse than if you were living in a metro area. And even those metro areas, the outcomes aren't something we should be proud about. And so I think there's a massive opportunity to take what we do in brick and mortar and obstetrics care, leverage telemedicine, leverage strategic partnerships with critical access hospitals, with rural OBGYNs, with doula clinics, and unique relationships with insurance companies to be able to basically export the awesome care we deliver, but in rural counties, solving a massive, massive problem. So we're very excited about that. And there's just a bunch of things that are happening on the macro level that I think suggest that timing is right. So put politics aside, the big beautiful bill has significant money going into re-engineering the rural healthcare ecosystem. Look, over the next 5 years, we're either as a country going to do that, and I want to be part of that, or we risk flushing $50 billion down the toilet and we're right back where we are. So I hope it's the former, and I hope Hera is part of that.
Something that I like from what I'm hearing is you're very focused on outcomes and protocols, but you yourself mentioned when you joined Hera, you made sure to visit all of the practices. Mm-hmm. I'm curious to hear about any patient interactions that you've had where you've seen or talked to them about how their care has actually changed from before they were, helped by Hera and after.
Yeah, I haven't had those specific conversations, frankly, but I do think it's hard to take what we built at Hera and make it really obvious to a singular woman, right? So like from a pop health perspective, you can look at the preterm birth rates, the appropriate C-section rates, protocol adherence, and you can say, look, we are doing everything that is improving clinical outcomes. But, pop health stats really break down when you sort of get to the individual. I think what is probably invisible to the patient, but is really special within what we've set up, is that there's a connectivity between our MFMs and our OBGYNs, between our MFMs, OBGYNs, and our laborist group, between all those folks and a bunch of ancillary services that we provide that are absolutely needed for world-class outcomes in maternity care. And so what I mean by that is, like, we have behavioral health specialists. We have nurse practitioners that run a diabetes program. We have addiction specialists. We have social workers. We have genetic counselors. The list goes on and on and on. And so it takes this multidisciplinary team. And so if you're a patient and you experience Hera, it's like you just showed up and the world is coordinated for you, right? Mm-hmm. If you're not in the Hera system, you probably feel very similar to what we've all felt, is you're getting bounced around from specialist to specialist. Some things are missed. Not everybody's on the same page. That doesn't happen all the time, right? Like, I think majority of the time communication is decent, but the goal here is to make it absolutely certain that the patient understands what's going on. They're informed, they're advocating for themselves, and the clinical team that's wrapped around them are all on the same page and headed towards the same goals.
Right. So when speaking about some of these outcomes, what are some specific metrics that you're measuring, and what are specific protocols that you and Hera have implemented to drive those?
Yeah, it's I would love for at some point you get to Dr. Uriah and you could dig deep into this. I'm like a ER doc that has delivered a couple kids, but that's not my specialty. What I would tell you is that the most impactful measure we have is preterm birth rates. And so if you look at, and these are very, very well published stats, you can drill down to the county level and look at what preterm birth rates are. And so if you step back for a second, if you look at where United States ranks compared to other developed countries, we're somewhere at the bottom, not something we should be proud about. There's a lot of things that are happening outside of just core obstetrics care that are driving that preterm birth rate. And so if you think about the chronic disease burden, so that makes pregnancies at risk or high risk, you have obesity, diabetes, and then you have greater access to fertility treatments, and then just the stats that women are having babies later in life. All of these things are confounding variables that are driving us in the wrong direction. Some of them are preventable, but massive sort of pop health issues. And then if you take a step down and say, well, what can Hera control? I think there's a couple things. One is when a mom comes through, what type of screening is being done to ensure that risk is identified, and if needed, referral to an MFM is done. For high-risk pregnancies, what's being done to ensure that very simple interventions, like we're talking about progesterone and aspirin that have been around for a long, long time, not expensive, really simple. Are they being put on the right protocols? And all of these things, and then are women's diabetes or chronic medical conditions being appropriately managed during pregnancy, so we have the best chance that they're going to be delivered on time and not early. And all of this translates, like in financial terms, to babies born early, baby goes to the NICU. NICU days are incredibly expensive. And then oftentimes, and unfortunately, those babies grow up to be kids and adults with chronic medical illnesses. So like there is the tail on the cost of these things is dramatic. And the frustrating thing is that the interventions are cheap and simple. It's about identifying them early. So we've spent a lot of time, what I would say, hardwiring that identification of risk, intervention of risk early, and ultimately sort of a team-based approach to ensure that, the MFM and OB that's taking care of them in an outpatient also is on the same page as if they're not available for the delivery, that the laborist is there for the delivery, and they're on the same page. On C-section rates, look, you're never going to drive C-section rates to zero. There are very good reasons to do that procedure. But I call it appropriate C-section rate, and there's NTSV and other ways to measure this. But the reality is that we have a societal norm sometimes to prefer C-sections, right? It's controlled. It means that you can kind of time the delivery to time it with the rest of your life. It could be with work. It could be with other matters. But we also know that a vaginal birth long-term is better and less expensive. And so we have protocols to identify women that, are at risk, but maybe if you intervene earlier, you could prevent having to go down that road.
So if I'm a woman who's being recommended one of these protocols, are there ever any instances where they have issues with payers or any government regulation that are roadblocks to getting that preventative care?
In healthcare, no way. No way. I mean, healthcare is so complex. There are always those barriers. And I think what's clear to me about Hera and what I'm proud about in terms of representing them is that, despite the complexities around reimbursement or medical necessity or differencing opinions between like an insurance company that's a million miles away, that's never seen the patient and what the doctor thinks, we simply do the right thing, right? And we clean up the other pieces of that in the end. And so like I think it's absolutely important that there is something really sacred between a physician and a patient, expecting mom. That interaction you should never mess with, right? You can make it more efficient, you can make it you could improve it, but that connectivity is where the special stuff happens. And so we just encourage our docs to do the right thing, right? And then all the other noise in healthcare can be fixed or not fixed, but let's focus on patient care. Do
you feel that Hera's collaborative healthcare model helps drive that forward as well?
I don't, I wish the answer was a simple yes. I think that in the 6 months that I've been here, the conversations that I've had with health insurance companies around the purpose of our model, our clinical outcomes, are very much appreciated. And I think it's also important to understand where insurance companies are coming from. Like, I had an opportunity to work with an insurance company for about a year when I was doing consulting, and it was eye-opening to kind of put a different hat on and understand the challenges they have. I truly believe people in healthcare, whether you're a doc, you're a biller in RCM, you do care management at an insurance company, like you work for a PBM. I think everybody, by and large, joins healthcare because they feel like they can make a positive impact. Do we get lost sometimes in the day-to-day shuffle and metrics and financials and all this? For sure. But I think everybody sort of has good intentions. And so back to the conversations I've had so far, I think people appreciate it, or the insurance companies appreciate it. And what I've come to learn is that they actually struggle to measure these outcomes, right? And so they have billing data to go by, and there's a lot of things that get missed when you're just looking at billing data. And so we spent a lot of time building our data infrastructure and our data capture so that we can measure these outcomes. And where our conversations have led with insurance companies is, well, let us share our data with you. Let's partner on those. Let's build alternative contract structures based on those, so that, what we want, they call them members, we call them patients, but those moms and babies get what they need and frankly deserve.
Right. So when you're speaking about, data and, these interesting models, I'm curious about, from your perspective, what are some trends and opportunities that you notice that those in the healthcare space or interested in getting into health tech, what are some kind of low-hanging fruit opportunities and trends you feel like are ripe for the pickings?
Look, I think if you went to any medical practice, I think you would see, if you had the right data, practice variability. And some practice variability is fine because there's a lot of art to medicine, right? But massive practice variability is a problem, right? And so, I can tell you that the extremes typically are not the right answer, and the truth or the target is somewhere in the middle. How you get there around physician coaching and trying to sort of take data and translate it to like what's happening clinically, there's a nuance there. But looking at practice variability and trying to shrink that, absolutely an opportunity all day long. The ability to take what I would call non-discrete data and make it discrete and reportable is a massive opportunity.
Right. Unstructured to structured.
Yeah, well put. And so if you take like the challenge is you want to have an interface that works well for docs. Like, look, seeing a patient, it's a conversation, right? And you're basically documenting that conversation and getting out of like clicking every single box. Like, you're not going to get good data. But if you can just tell the story and then pull that data into structured data, and then have great reports, man, that changes things quite a bit. And I also think, like, if you have the data and you present it to physicians, there's usually aha moments, like, oh, I had no idea. Oh, there's a different way to do this. Like, let me go talk to my doc colleague down the road that like has better outcomes, or whatever the metric you're trying to measure. What are they doing that I'm not doing? So there's a lot of teaching, coaching. And I think that inherently everybody wants to excel. And look, most physicians are fairly type A overachievers, right? They didn't get into medical school and get through all that training because they didn't care or they weren't motivated. They're very motivated.
Right.
But to be able to give them the visibility to make change, like, I think that's one of the keys.
It's all stick, no carrot.
Yeah, that's right. And look, I think that one thing that's really unique, and I didn't know this when I joined, but I'm really pleased to see it, is that oftentimes when you bring a bunch of practices together and you get professional money in, there's this sort of stick approach to driving productivity in the financials. I think there's a much more nuanced, longer lasting way to affect change, which is really building a rapport with the doc leadership, and equally understanding their world and not just looking at a number and saying that number needs to move, but like, why is that number that way? And let me understand your world so I can live in your shoes, and then partnering to move those metrics, but partnering them in a shared decision way where the physician supports it, they ultimately own it, and the result will be longer lasting as a result.
Amazing. And finally, what is your vision for Hera Women's Health over the next decade?
I would love to be able to come back and tell you that number one, because of our sort of rural pursuit, I've started thinking about not being a Vegas practice or a Reno practice or pick your city. I start thinking about us as a Nevada practice, Arizona practice. I would love to be in a bunch more states, not every state. I think going deep is incredibly important here. And then I'd love to come back and say that we took those states from a March of Dimes score D to an A, and that we've completely changed the outcomes for moms and babies in those states.
Amazing. Well, I look forward to you coming back and showing us that happened.
All right, let's give it a rip.
Andy, thank you so much for joining us today.
Thank you. Appreciate it.